Hello and welcome to the Alliance for Home Health Quality and Innovations webinar on ACOs, bundling, and population health management, hospital strategies for optimizing post-acute care. My name is Teresa Lee and I am Executive Director of the Alliance. And just by way of background, the Alliance was founded in 2008 and is dedicated to the mission of sponsoring and fostering research and education on the value that home health care has to offer to patients and to the entire U.S. healthcare system. Today's webinar is the first of the Alliance's Innovation Perspectives webinar series. The Innovation Perspectives webinars seek to provide diverse perspectives on home health care's role in innovative healthcare delivery models. Our webinar today will focus on how hospitals and health systems engaged in ACOs and bundling arrangements plan to optimize post-acute care services, identify the key capabilities required and associated with post-acute care coordination, and evaluate specific post-acute care providers. We are extremely fortunate today to have two guest speakers, Brent Hardaway and Lori Peterson, to shed light on this topic. Brent Hardaway is the President for Population Health Management at Premier Healthcare Alliance. He has 25 years of experience in various facets of healthcare organizations and strategy development. He has led projects ranging from financial turnarounds to hospital physician alignment. Premier Healthcare Alliance is a collaborative healthcare alliance of more than 2,700 member hospitals and health systems and over 90,000 other healthcare facilities, including post-acute and ambulatory, with the mission of improving the health of communities and leading the transformation to high-quality, cost-effective healthcare. Lori Peterson is the founder of Collaborative Consulting. She has been involved in the healthcare industry for over 20 years with a honed expertise in post-acute and long-term care. She has served in several capacities, including business development, strategic partnerships, operations, management, training, and development. As the founder of Collaborative Consulting, she's currently working with post-acute and community-based providers to facilitate organizational positioning, readying, and to encourage participation in models of accountable and integrated care delivery. I have just a few housekeeping notes before we get started. First, our guests will speak for approximately 45 minutes and will leave the remainder of our time to answer questions. Please note that this is a webinar and we control the slides on our end, so don't be surprised if you cannot flip ahead. Second, your lines will be on mute. You can submit questions to be answered during our Q&A period through the in-meeting chat box on the Fuse webinar software that's on your computers or other devices. One warning, if you send a question to everyone, everyone will see your question. You can send a question to the speakers to be answered in the Q&A period by sending a question to me, Teresa Lee. Finally, please be aware that we are recording this webinar, including the Q&A period, so that we can provide a playback on our website for those who were not able to participate live today. And with that, I'm going to turn this over to Brent and Lori.
Thanks, Teresa. Can you hear me okay?
Yes, just fine. Thanks so much.
Terrific. And just to make sure Lori's with us as well? I thought I had seen or heard her earlier.
I thought so too. Do you want to go ahead and start, and we'll work on making sure that Lori is on and able to speak?
I will do that.
Okay, great.
And I'll just let you know when to flip the slides forward. So let's go ahead and do that.
Great.
Well, good afternoon, good morning to some of you. I'm Brent Hardaway, as Teresa mentioned, and it's a pleasure to be with you all this afternoon. The purpose of the work that we are, or the information that we're going to be going through, is listed on this slide. And the objectives that we've got for the time that we have together today is to provide you with a little bit of background on population health and what is going on in terms of accountable care delivery and how that is impacting both the acute providers and the post-acute care providers. We're also going to talk about the capabilities that are required by post-acute providers in the population health space. And we're going to talk with you a little bit about a tool that we have developed that helps post-acute providers with a better understanding of where they are in terms of possessing those capabilities, what those capabilities are, and whether or not they possess them. And throughout, we're going to try and provide you with examples of where and how this is working in certain systems and certain geographies across the U.S. So in order to meet those objectives, we've got some background materials, we've got some statistics on post-acute cost and utilization, we've got an overview of what it means to be an accountable care organization and the strategic considerations that come about with developing that post-acute, in developing the post-acute component in accountable care, and then we'll talk a little bit, as I said, about PAC assessment tools. So we'll go to the next slide, and the next. What you'll hear throughout this presentation is that we are in the midst of trying a lot of new things, Some of these things will work, some of them won't. But as you can see from Winston Churchill, that we're used to trying a lot of different things. Go on to the next slide. At Premier, we see the evolution of payment models driving a lot of this change. And as you can see along the top of this particular slide, we've listed out what we believe to be the logical evolution, going from where we are today in terms of most all providers taking some sort of reimbursement cut, or at least lowering the increases in their expected reimbursement, to adding a value-based component to almost all providers' compensation or reimbursement. Then moving to medical home, and then moving to episodic payment systems under bundled payments, and in the accountable care organizations, moving to shared savings. And all of that, at some point, we believe will end up in some sort of global payment system, a total cost of care payment. And whether that be for an episode or whether that be for a population is still to be defined. But we do believe this is the way that the reimbursement system is going to go forward in over time. And whether it's 3 years, whether it's 5 years, whether it's 10 years, we do believe we will end up with some sort of global payment. I'm not going to go through the capabilities, but you can see that underneath and by type of reimbursement, we believe there are certain capabilities that hospitals and other provider systems need to possess in order to be successful. And you can see it goes from being a single entity or a single system to moving beyond that system to a broader view of an episode of care and the thing that you have to have available to you and what you have to be good at in order to be successful, and then moving into population management, where it truly is a whole new set of capabilities that systems have to possess in order to be successful. Let's move on to the next slide. As I mentioned, we're doing in the United States a whole lot of new and different things. And through the Center for Medicare and Medicaid Innovation, we are, in fact, innovating. And so a couple of the following slides, I'll show you that there are a lot of systems participating in these different types of demonstration projects, innovative projects, and pilot projects. So the first one is the Medicare Bundle Payment Initiative, or the Bundle Payment for Care Improvement Initiative. There's over 500 systems that have been awarded contracts with Medicare, and you can see on the key at the bottom, there are 4 different types of models, and I'm sure you are all aware of these. But again, the point being made is that the geography and the expansion of these types of demonstration projects we're seeing across the U.S. So go to the next slide and talk a little bit about the four models. And again, I'm sure you are all aware of these, and you can see also the point to be made is that the Model 2 is the one where the most contracts were awarded. And Model 1, retrospective across all MSDRGs, I think might have been, I don't remember off the top of my head, the fewest was either 1 or the number 3. But again, what is happening here is that disparate types of providers are having to come together in order to take a payment for an episode of care, and whether that's being paid prospectively or whether it's being paid retrospectively, that there is significant change occurring. Let's go to the next slide. The other point to be made here is that the number of Medicare ACOs across the country is growing rapidly. And over the past year and a half, approximately 250 contracts have been awarded to provider systems or others to create a Medicare ACO. And you can see that by state, there's concentration in those with the large population areas. But there's also a whole lot going on in the Midwest and the Upper Midwest around the development of a Medicare ACO. Let's go to the next page. And you can see the number of Medicare ACOs, so 254 in 43 states. The first of those were part of the primary care group with the physician primary PGP demonstration. I never can remember what that acronym stands for. Then the next large group that became Medicare ACO, 32 CMMI Pioneer participants, which started in January 2012. So they have been around for just over a year. 30% of those are physician organizations that have been awarded the contract, not hospitals, not other providers, but physician organizations, which is an important point. And then the remainder are part of the Medicare Shared Savings Program, or the MSSP program, and there have been 3 tranches of contract awards that started in April of last year. The last contracts were awarded in January of this year, and there is another contract awarding period that will occur in January of 2014. So again, a lot of movement towards accountable care, and this is just Medicare. This does not tell us about the work that's going on from the commercial payer standpoint. And although we don't have great numbers on that, it is our belief and some literature that suggests that there is at least this many of commercial ACOs in the marketplace today. So a tremendous amount of activity around the development of Medicare ACOs. I'll pause there and see if we've gotten Lori on the line with us.
Can you guys hear me?
I can, yeah.
Oh, fantastic. I'm on the line.
Good. Lori, anything to interject at this point?
No, you're doing great.
Okay, all right, good. Then let's go ahead and go to the next slide. I wanted to spend a little bit of time and talk with you about our view of an accountable care delivery system and the components, the broad components that make up that delivery system. And you can see all of those listed here. In the Premier's Capabilities Framework, we go through these 6 core components, and underneath each of these 6 core components, we create operating activities. And you'll see some examples of that as we talk about the Post-Acute Capabilities Framework. But In this construct, we have these six core capabilities, and we have 180 or so operating activities. And so systems can judge themselves and determine the gaps that they have to fill in order to become a successful accountable care organization. And also, just for definition's sake, we use the phrases accountable care delivery and population health management pretty much interchangeably, so not to throw anybody off with any distinctions around that. But as you can see, the six core capabilities that we have here, the people-centered foundation, and that really is the principle of defining care around what is needed by the population that we are serving. And that is being able to engage as well the people that are a part of that population. And lastly, it is how do we assure that the people in that population are in fact taking accountability for their own care as well. So there's a lot that goes into that first capability. The second is the health home. You probably hear this referred to more as patient-centered medical home, but it really is the foundation of the accountable care delivery system. A high-value network, we're actually going to do a little bit of a deeper dive into in just a moment, so I'm going to leave that, except just to say that it is the continuum of care that includes all of the providers other than the primary care or the patient-centered medical. We also have to have an accountable care leadership structure and an organizational structure and an infrastructure that is developed that does a lot of things that have not been done in provider systems previously. An important component of accountable care leadership is that we involve physicians from the outset and in a manner that allows the physicians to have significant input into the decision-making process around this delivery system. Population health data management is just that, the information that we need to manage this population. And this is data that no provider has had previously. This is information that health plans have all had. And there's a lot of work being done these days to help identify the vendors that are out there and to understand what data is necessary and what we can get out of claims data, because that's really the only fully longitudinal data that we have around an episode and for a population. And then finally, payer partnerships. There's still a role for payers to play in this structure, and we'll talk more about that in just a moment. Okay, let's go to the next slide. As I said, we'll do a deeper dive on high-value network, and as you can see, the full continuum of care in the high-value network ranges from hospice care to long-term care, home care, all the way to pharmacy. And the important component of the high-value network is to assure that care is coordinated across the continuum and across an episode. And that requires a significant amount of work on the development of care models, a significant amount of work on the development of a care management system, and assuring that the providers are taking part in the development of those systems and then abiding by or adhering to those the care models and the systems that we have put into place. Let's go on. And then, of course, the post-acute spectrum being a critical component of that high-value network. And as you can see in the bottom left-hand corner, it does serve as a step down from the intense acute hospital services, but I think as or even more importantly is that its role as a partner in the management of chronic conditions. And you've all heard the statistics, but chronic conditions are the area where there is the greatest opportunity to lower the cost of a population. and the 5% of the population accounting for 50% of its costs, we know who is in that 5%, and we have to target that 5% in order to take out unnecessary costs that's in the system. The key ACO attributes over on the right-hand corner we'll talk about in more detail in just a moment, but these are, we spoke earlier about the key components of the ACO construct overall, those 6 core components. These are the 6 core components of the post-acute piece of an ACO. Let's go on to the next one. Just a couple of questions, and Teresa, I don't know if you want to open up the lines or if you want to save people's answers for a little bit later on when we get to the question and answer, but these are just some questions that we would ask, and we would love to hear your answers to when we get to the right time. But has your organization identified your accountable care partners? Have you assessed your capabilities relative to managing the population? And for those that have you closed the loop on that first bullet, in that taking that information to potential accountable care partners? Because we know from the hospital system side that there is a lot of definition occurring as to what they are looking for from a post-acute provider, and then how do they go about identifying those post-acute providers that they want to have as a part of their network. And so it would benefit those post-acute providers to actually potentially take the first step and saying, this is our plan for moving into population health management, and here's where we are. We may have some more work to do to get to that point, but this is where we're headed. Lori, I don't know if you want to say something more about that.
Yeah, no, I think I'll just add in here a piece of that. It's not really a question, but it's adding on to, closing the loop. And I think that you hit on it, Brent, but incredibly important to know how to articulate your value in a way that your accountable care partners want to hear it. And we might touch on that a little bit more, but I think that's a piece of closing the loop and, approaching those potential partners and really being able to articulate the value from their point of view.
Right. Good. Okay, let's move on to the next slide. And we're going to spend just a little bit of time talking about cost and utilization from the post-acute care side, and also to provide you with some information that we have that is related to the accountable care delivery and some accountable care organizations, specifically Medicare shared savings programs, that have received data from Medicare that identifies opportunities, and some of you may be surprised to see how much of that opportunity is in post-acute care. Let's go to the next slide. This is just a slide illustrating again, the progression of the payment system, and we are all very well aware that Medicare and other providers are moving towards value-based purchasing, trying to move away from the volume-based reimbursement system that we have today to a system that has a little bit more balance and doesn't necessarily take volume out of the equation, but adds a significant component that is relative to value. And all of the providers listed across the top are moving towards or are already in some sort of value-based purchasing reimbursement system or a pilot. And then down below showing how the different pieces of the continuum are being linked together underneath some of these demonstration projects. One of the problems that we have with medicine in the United States, or at least the economics and the payment structure, is that we are so siloed. And so a lot of the work occurring in terms of the development of demonstration projects and the creation of different types of reimbursement systems is an attempt to get rid of those payment silos. And we realize that there are all kinds of rules and regulations that actually don't allow us to practice across silos, that actually harm us from a reimbursement standpoint if we move a patient too quickly or something like that. So there's a lot of change that has to occur from a regulatory standpoint before we ever get to the point where we can, in fact, care for patients across these silos. But again, these demonstration projects are helping us in terms of providing some waivers to some of those rules and regulations. Let's go to the next slide. I apologize. Go back if we can. I do want to note that at the very bottom where it says Congress speeds up value-based purchasing and creating national bundling program in CY 2013. It is our belief that there will be a national bundling program, not just the demonstration project that's coming out of the Innovation Center, but in fact we will see a national bundling program through Medicare that in fact is going to put together an episode-based payment system for all patients or all DRGs within the next couple of years. Sorry, go ahead to the next page. I'm not going to spend any time on this except to say that we know what the issue is, and this growth curve is no different than the overall growth curve for all medical costs in the United States. But you can see that post-acute care certainly has its share of the increase, and one of the issues that we're having to deal with throughout these changes is how do we lower this increase? Not necessarily decrease the cost, but at least lower the increase. Okay, next one. This is information that I mentioned that we had we're working with a lot of accountable care organizations. This is information that they received from Medicare. They are an MSSP contracted ACO that shows where the opportunity is for lowering or taking costs out of the population. And you can see for the columns the expense for the assigned beneficiary, and then the average for all MSSP ACOs. And what they were saying is, what this hospital or this system was saying is that how much could we save if we took 5% out? And that number would be $7.3 million. But what is the opportunity if they were actually able to reach the MSSP average? And so you could see the total for this system, this MSSP, was $21 million. What's most revealing, however, about that $21 million is that $14 million of it is coming from home health. And you can see that the expense per ACO assigned beneficiary was $1,664 for this system. The average for all MSSPs was $527. That's where they got that $14 million. Let's go to the next page. This is a little bit hard to see. I apologize for that. But this, in fact, shows a year-over-year change for, a year-over-year change for the ACOs that were in place in 2012. And we realize that a lot of the change that is occurring may not be a function of the work they're doing as an ACO because they've just been an ACO for a short period of time. But what this is showing is that there has been a 15.6% decrease in the expenditure per assigned beneficiary in these ACOs. So from $867 to $732. But in fact, for these particular ACOs, home health has gone up from $484 to $538. Overall, for these ACOs, the total expenditures per assigned beneficiary has gone up, but only slightly, from $9,832 to $9,895. So a very, very small increase in the overall cost of taking care of the beneficiaries that are in these ACO populations. Let's go ahead and go to the next one. And can we zoom out on this? This is thank you. This is a slide that shows an episode of care for a group that we are working on a bundled payment for, that again has received data from Medicare, and this is for one MSDRG. And I just note a couple of points on here that we have identified a number of opportunities when comparing to a managed benchmark in terms of the skilled nursing facility and the home care. And so I think what we are seeing and hearing through the data points that we are getting is that there is going to be a significant concentration on post-acute care for these populations. And don't need to dwell on that. Just the point to be made is that there will be a microscope on these areas. Let's go to the next one. Okay, strategic considerations. Let's go ahead. We've got this in two different frames of reference, one from the ACO's perspective and one from the post-acute care perspective. And we know that the ACOs are, as I mentioned, doing a lot of work on identifying who they want to have in their network from a post-acute perspective. And they're doing assessments based upon the data that's available, and MedicareGov.org has one of the best receptacles of publicly available data around this. There are also a number of capabilities assessments that are in the marketplace that folks are using, and we'll talk about the one that we've created in just a moment. Those that are doing this are doing it and narrowing their list to the high performers, and then approaching those to be a part of the network. And then also they're having to make decisions about how to partner, not only who to partner with, but how to partner with them. And the choices that we see most often today are 1, owning, 2, outsourcing, and 3, joint venturing. Outsourcing is the predominant model that, in fact, that they're the only interaction between the acute care provider and the post-acute care provider is in a discharge planner or a social worker in some instances. Let's go to the next slide. Lori, you want to touch on this one real quickly?
Yeah, sure. So basically, as Brent said, we're looking at this from two perspectives. One, from the ACO perspective or the hospital perspective, and then 2, from the post-acute care provider perspective, and in kind of that strategic considerations and positioning. And so the first one, really in understanding the trends. And so Brent's talked a lot about what the trends, the demos, these are actually in motion. And so really getting a grasp on what, as post-acute care providers, do we need to understand? What do we need to learn? And how do we go about learning it? So I know that sounds kind of basic, and yet with so much uncertainty in the market and so much change, it's a critical piece in really honing into what don't we know enough about, how are we going to learn it. The second piece is basically understanding your market. And so some of these are going on, these initiatives at a federal level, and some of them more in some markets than others. And so really getting a handle at your local market. What are the hospitals doing? What are the physician practices doing? Who's participating in ACOs? Who's participating in bundled payment? Are there any community-based care transition initiatives going on? These are often the entry points to building some of these stronger linkages and relationships between acute and post-acute. And then what are the continuum strategies? What's your continuum strategy? What are your skilled nursing facilities doing in the market, and how might you look at partnering and being part of their continuum? So that's kind of a broad. What do we need to know? How are we going to go about it? The second piece, really getting a good handle on what's happening in the external market, and then the third piece is stepping back and doing your own internal assessment. And we're going to talk a little bit more about the post-acute care assessment tool. But in addition to that, really looking at your culture, your ability and your fluidity to make these changes, your capacity for new service development, and actually taking your core capabilities and creating new value with what's happening in the market. It's one thing to really understand the trends. It's an entirely different thing to be able to execute on them. And so really taking that internal look from an operational, clinical, culture, leadership, etc. perspective. Next slide. Brent, do you want to touch on that, and then I can touch on the tool a little bit more?
Absolutely. So one of the questions that we are answering with our clients and our members is what are the attributes of post-acute care provider and partner that are going to be important, and what is it that we're going to be looking for from an accountable care perspective. And you can see on this page and on the next page, we've got a number of capabilities listed, and then what we suggest would be the minimum requirements, and then what we would suggest to be the ideal requirements. And I'll just talk about a couple of these. The post-acute continuum, for instance, the minimum requirement certainly would be a single service. What would be the ideal requirement? Who would an accountable care organization like most to partner with? And that would be someone that could be the full continuum. From skilled nursing to home care to long-term care to palliative care and everything in between. The one-stop shop certainly takes away a lot of the hassle that's required in terms of defining contracts and creating a narrow network. But in addition to that, you need to have better clinical quality scores, better service quality scores, better patient satisfaction than any of the local providers. So it's not just to have the full continuum, but you have to have a full continuum that performs better than those in the local market. Let's go to the next slide. Case management, making sure the ideal requirement is making sure that we participate as a post-acute partner in management across the entire episode of care, not just, again, continuing to operate in our silo, but operating as a system across the episode of care. The medical champion, vision, leadership, all of those go into what Lori was talking about earlier, just in terms of culture and making sure that there's a fit from a vision and leadership perspective, and then making sure that we have or we allow for the physicians to be on site and helping drive improvement. Let's go to the next slide. And we see a number of different coordination models from the post-acute perspective. One is as the credentialed contractor, so continuing to be a contractor, but assuring that our cost and quality and satisfaction are better than others. Therefore, we get preferential contracts. The partnership is a little bit more than that in terms of providing those services, but being able to make guarantees as to how much volume we can accept. And whether it's 50% of the accountable care organization post-acute patients or whether it's 100%, we have to make sure that we have the capacity to take that on. And it's also important that we've got a care management system and a transitions of care system in place that seamlessly moves the patient from the acute care setting to the other post-acute settings. And then the driver model is one where we are actually willing to take on full accountability and full risk from a financing perspective. And there's not a lot of folks doing that in this space right now, but we believe that we'll move more and more towards that as the reimbursement models continue to change. So, Lori, you want to mention anything more on that slide, any examples?
I think you're exactly right, Brent. I've seen a lot on this, the contractor piece, which often looks like contracting with a managed care entity. The partnering piece we're seeing a lot more of is, like you mentioned, creating these preferred provider networks and actually establishing, memorandums of understanding and how post-acute care and acute care is going to work together and benchmark that going forward. The driver piece, I probably in your court, I don't see a lot of that yet. And however, lots of conversations around with those post-acute care entities that can actually be that, I hate to use this language, but I can't think of anything else, that one-stop shop where basically once that person leaves the hospital setting, they're managing it, for the entire rest of that period from A to Z on the post-acute care side. Not a lot of that yet, but definitely moving that direction.
The other thing I'd add to that, and what we're seeing happening is that in that particular instance, that the post-acute providers don't all necessarily have to be under one ownership, that we in fact are seeing partnerships being created across post-acute providers that allow them that umbrella organization to approach the acute care or the accountable care organizations.
Exactly, and I'll just add real quickly there, Brent. In fact, when you mentioned kind of the strategies around outsourcing and JV and acquisition, where I'm seeing most of the joint venture happening is on the back end with the post-acute care. So skilled nursing or CCRC looking to affiliate with home health providers, home care providers, so they can actually better position themselves to be a partner with the acute care.
Okay, let's move on to the next slide. And Lori, you want to just continue? I think we've got 5 or so more minutes.
Sure. So basically, what we did is we came up with this post-acute care capabilities framework and assessment, and the function or the purpose of this is for a post-acute care provider to actually take a look and say, okay, am I ready to participate in some of these accountable care models? So that's one way this tool is going to be used. The second is actually hospitals and hospital systems that are looking to partner and or work more closely with post-acute care providers in them having a tool to actually assess post-acute care as well. So those are kind of the two primary purposes that we're looking at, and then also that if a healthcare system actually owns and operates post-acute care, having them be able to use the tool for an assessment as well. So next slide. I think I just said that slide, so let's go ahead and go to the next slide. So basically, here's a picture of the tool, and again, the tool was designed primarily in complement to what Premier is using with the hospitals, and it's not designed as an audit. It's more of a high level. As a post-acute care provider, what core components do I need to have in place? So what are the core components? And you'll see here you've got the person-centered foundation, high-value PAC network, which Brent's already talked quite a bit about, the payer partnerships, leadership, and then go ahead and go to the next slide. Post-acute care coordination and population health data management. So those are really the 6 core areas of focus. And then what the tool does is actually take it to one next step and say, okay, what capabilities do I as a post-acute care provider need to have in place to actually achieve these core components? So looking at, here are the components, what capabilities do I need to have in place? And then the third takes it to the next level and looking at the operating activity. So basically what systems, what processes are in place or do I need to put in place to make sure these capabilities and components are functional? And then the tool actually allows you to self-assess. And I don't think we've got a slide for that, but I'll just say go ahead, go to the next slide, let's see. No, we don't. But basically what the tool does is actually allow you to self-assess in these areas, and then where do you need to be focusing on for improvement? So what areas might you look at within your own entity to improve upon? So Brent, do you want to say anything else? I know we're running out of time, so I'm trying to rush through it.
No. The only thing I'd add to what you just said is this is just one tool that's out in the marketplace, and there are any number of these. And what we're suggesting to you is, don't necessarily use this one, but use something. I think that the market is moving so quickly today, and that the changes occurring are going to require a better understanding by the post-acute care providers of the capabilities that they're going to need and that they already possess and where those gaps are. But I know for a fact that the accountable care organizations are going through this process today to identify who they want to have as a partner. So it will just benefit you to know where you are and what you need to do in order to be a partner within those networks. Anything else, Lori, that we need to talk about?
I think that pretty much, I know that we wanted to leave some time for questions, and so I think that pretty much wraps it up for us and open it up for questions.
So, Teresa, I think unless you've got any other things that you'd like for us to talk about, we're ready to take the questions.
That's terrific. Thank you so much. This is, the two of you have shared such critical information, I think, to this community. And I have just let me first say that I want to encourage everybody who's dialed into the webinar. If you have any questions, if you could please submit them through the chat box that's through the Fuse meeting software. And in the meantime, while people are thinking about their questions, I thought I would just throw out a couple quick questions. First, you talked about the fact that, that there's a growing interest, obviously, in hospitals and health systems and ACOs and bundling. I'm wondering if you have a sense of what proportion of hospital and health systems at present are involved in these arrangements. Do you see them growing, and how quickly? And then also, of the ones who are partnering with post-acute care providers already, do you have a sense of how many are pursuing ownership versus outsourcing versus joint venturing with post-acute care? Because you mentioned all three of those approaches.
Right. Yeah, I'll take a quick stab at that and then ask Lori to comment. So just from an overall numbers perspective, I think like we were talking about before, there's 500 or so accountable care organizations in the United States, covering probably all 50 states by this point. That's 4,000 hospitals, so 10-12% of hospitals in the United States. I it's probably closer to 20% because some of these are large systems. So there's a lot of activity, and just the growth over the last year is indicative of that. I also would suggest that, another proxy is that there's about 200 hospital members in Premier's accountable care collaboratives. And we've got, as you mentioned, like 2,700 hospitals in the alliance. So that again gives us something around the 10% number. So I think there's a tremendous amount of, and that's 10% that has grown over the last year and a half to 2 years. So that's a pretty significant growth rate. The second question was of those different types of partnering models. I think we mentioned before the preponderance of those are in that second model. I can't remember what we call it, the contracting model, and very few in that joint venture model. So I see that changing, but there hasn't been a lot of change in that to date, as far as I'm aware. I don't know if Lori, you have any other thoughts on that.
Yeah, I'll just add too. When we talked about the question around kind of the percentage and the numbers. One thing that we've not said at all today, but I'll just throw out the number right now, is that there's 2,000, I think over 2,000 hospitals right now that are being penalized for readmissions. And so if the hospitals aren't focused right now on accountable care or bundled payment, they're absolutely focused on readmissions, and that's a huge opportunity for post-acute to start developing this stronger linkages or stronger relationships. So I know that's kind of a side note, but I'll throw that out from kind of a numbers perspective. The second part is a question around JV and outsourcing, and Brent, you're absolutely correct. Mostly what we're seeing right now is the contracting model and then the creating of the preferred provider networks. In fact, if folks want to take a look, there's a couple examples. I think it's Lehigh Valley in Pennsylvania, and I could be wrong about that. You can follow up with me directly. They've got a model that might be worth checking out from that contracting outsourcing perspective. And then the other one would be Summa Hospital in Ohio. They've got another good model that's worth taking a look at, so you can see kind of from the hospital perspective how they're refining their network of post-acute care provider relationships.
That's really helpful. I've gotten a lot of questions about being able to access your presentation after this webinar. I think that what we've talked about is posting a recording of the webinar on the Alliance's website, so everybody will be able to view the playback. And I'll defer to the two of you as our guests as to whether you'd be willing to share maybe a PDF version of your slides. But I recognize that's up to you all. And I'll give you a chance to think about that. I've got a couple questions here, a couple really good ones. The first is you provided some terrific detail on the cost of home health in the context of ACOs and overall Medicare spending in your presentation. And, it's sort of early in your slides. I guess the question here is, were some of those numbers related to the cost of home health related to overutilization or greater utilization, and is there an expectation that you would reduce the cost, and how would you see about getting it done?
So I think that the information that we have received from the accountable care organizations relative to the cost per beneficiary and the total cost for the different sites of care, it indicates to us that relative to other models that there is overutilization. of these services. And the reason that you can suggest that it's overutilization is because these are all Medicare beneficiaries. And so the payment level per unit of service is going to be very similar. So the only difference could be in the number of services. So, and you know, it's also premature to say it's overutilization. It's a difference in utilization. And what we have to continue to look at is the appropriateness of utilization. And if it's really high in home health, for instance, is there another area where there is an underutilization that maybe it's just a matter of better balancing and that's it, better balancing of the utilization of those services.
Well,
Teresa,
and
does that answer the question?
I think it sort of does. I mean, I think that in a way what we need is a better understanding of exactly what, you know, because, you know, the data is limited, right? You've got dollar figures and you've got, you know, maybe units, but it's hard to know exactly what care is delivered and what's appropriate and what's not. And I think maybe what we're seeing, too, in the context of these new payment arrangements is that people are feeling out what makes sense and what doesn't, and there may be some substitution effect between SNF and home health that's leading to increased use, and that may be the cost-effective thing, but it's hard to know up front, right?
That's right. Well, and the Dartmouth Atlas information is still the best source of understanding where lower utilization, lower costs, but better outcomes. And that's where we have to the piece that we don't have in here that we're all waiting for is what are the quality metrics and what are the outcomes associated with the financial component of this.
Absolutely.
And so I don't think there's a lot of people making a lot of decisions based upon the dollars, but you've got to be really careful with that.
Right. I've got a couple more really good questions here. This one comes from Jack Lewin with a Medicis and Clinically Home. He says here, to what extent do you all think the traditional home health model will be shifted to new models as ACOs employ global payment or capitation arrangements, and how fast would it happen, if so?
Lori, you want to take that one?
So basically, the question is around traditional home health models. At least that's the way I'm hearing it. What I think the important piece that Brent mentioned earlier is around the national bundling, and if that actually does happen, then your traditional home health models, especially as it relates to being in the fee-for-service world, will probably dramatically change. That's why I think it's important, if possible, and entities have the capacity to start experimenting with new models or new service development, transitional care coordination, partnering with those that provide community-based services. So really, as we're moving through this transition, having the ability to keep one foot in one world and one foot in another world. So it's a parallel strategy. Brent, I think I've heard you say the care redesign can't outpace the reimbursement piece. Hopefully I didn't totally destroy your quote on that.
Pretty close.
Yeah, but so I think yes. Do I think the traditional home health model will change? Yeah. How that will exactly look, I'm not entirely sure. But I think it's important to start understanding more about your own models, what's happening in the market, and then how do you start to fit in, and where are the opportunities to shift and look at different approaches and different models.
Okay, we've got a hard stop at 3 o'clock, but I've got one more question here that I think is really good, and it goes to the point that you all made about the value proposition and the need for post-acute care providers to really come forward and show their value. So the question here is, other than home care agencies sharing outcomes data regarding wound deterioration, falls, medication compliance, ER and post-hospitalizations, and so on, what data would be beneficial when marketing to area ACOs in hopes of partnering with them?
Lori, do you have a 30-second answer for that?
Oh gosh, it's so hard. I mean, yes, the outcome data, number one, for sure. Your readmission data, for sure. Your experience in other partnerships and how you've executed on those, absolutely. And then I think also being able to tie that back. Here's a 30-second. Whenever you're looking at what value you bring, ask yourself the question, so what, at the end of that statement. And that's what I mean by being able to articulate our value better. And to actually, once you say this about an outcome, ask yourself, so what, and go ahead and complete that sentence. So that was a very, very quick, but if that person wants to email me, I can definitely get into that question in more detail.
Terrific, terrific. This has been just a terrific hour with the two of you, and I want to thank you both so much for sharing all of your information. I want to mention that we have recorded this webinar. We do plan on posting the information, the playback on our website for those of you who may not have been able to make it either for the entire time or at all. So that will be available. And as I mentioned at the top of the hour, this is a webinar series that the Alliance is hosting on Innovation Perspectives. Our next webinar is planned for Wednesday, June 19th at 2 p.m. Eastern with speakers from the Coalition to Transform Advanced Care, or CTAC. So I hope that you'll join us for that as well for another hour or so on home health's role in innovative delivery systems. So thank you again, Brent and Lori, and thank you to all of you who participated today.
You're welcome.
Our pleasure. Thanks.
Okay, thank you. Bye-bye.
Bye-bye.